the root canals. Okay, so let us start today's session and we'll be talking about cleaning and shaping of root canals. As always, I shall be focusing upon the important aspects regarding your pre-PG examinations. As far as cleaning and shaping of root canals is concerned, previously it was called biomechanical preparation, but the more proper term these days is cleaning and shaping of the root canals. Okay. Basically, there are certain mechanical objectives. Definitely, cleaning and shaping means we would be using certain instruments and medicaments and irrigants inside the root canal. So, what are the mechanical objectives? Means what are the objectives with which we instrument the root canals for cleaning? The mechanical objectives for cleaning the root canal were given by Schiller. Okay, he was the first person to propose them, and the principal mechanical objectives is that firstly, we should prepare the root canal. It should be prepared as a continuously tapering funnel. As a continuously tapering funnel from the coronal area to the apical area. Okay, this means that we have to prepare the root canal, shape it mechanically with the help of instruments so that it becomes a constantly or continuously tapering funnel from the orifice to the apical area. Another important mechanical objective is that whenever possible, we have to preserve the original root canal anatomy. Although we are enlarging the root canals, it should not be like that. We are just changing the regular anatomy of the root canal. So preserve the root canal anatomy. The root canal should be prepared in multiple planes. We have to prepare the root canal into multiple planes. See, most of the time the root canals are curved. Suppose this is one root canal, which is having a double S-shaped curve. Then the planes for preparation should be one plane of preparation, another plane of preparation, another plane of preparation. So that's to preserve the original canal anatomy. The third mechanical objective is that the apical constriction. Previously, when we talked about the anatomy and morphology of the root and root canal systems, we saw that there is a phenomena called apical constriction. There is a landmark, anatomical landmark called apical constriction. So whenever we are doing cleaning and shaping of the root canal, especially the mechanical preparation of the root canal, the apical constriction, it should be kept as small as possible. As small as possible. These are the principal mechanical objectives for cleaning and shaping of the root canals. Now, cleaning and shaping is also called endodontic cavity preparation. Just like we do cavity preparation in the coronal or the crown portion of the tooth to receive the restorative materials, we are preparing the root canal of a tooth to receive the obturating materials. So this preparation of the root canal by means of cleaning and shaping is also called as endodontic cavity preparation. Just like we have got resistance and retention forms for the coronal tooth preparation, we have got endodontic resistance and retention features. So what are the endodontic retention form and an endodontic resistance form? Okay. Whenever we do cleaning and shaping of the root canal, especially the mechanical preparation, we have to incorporate the retention as well as the resistance form. What is meant by retention form? Retention form means development of nearly parallel apical one-third canal walls. Development of nearly parallel apical one-third canal walls. Okay. that prevent coronal displacement of your master cone. What is master cone? The primary Gattaparcha cone that is fitted to the working length, okay, to obturate the root canal. This coronal displacement of the master cone should be prevented by development of nearly parallel apical one-third of the root canals. This is known as endodontic retention forms. So we have to shape the root canal so that it is a constantly tapering funnel with apical one-third of the root canal nearly parallel. So whenever there is a master cone seated to the working length, it would be prevented from coronal displacement in an upward direction. On the other hand, if we talk about the endodontic resistance form, it means development of an apical stop while doing mechanical shaping of the root canals. We have to develop an apical stop that prevents apical displacement of your master cone. Okay, so we have to keep the apical constriction as narrow as possible, as we have seen above in one of the mechanical objectives for the preparation of the root canal. So when the master cone is placed for obturation inside the root canal, it is prevented from being displaced beyond the apex. So development of an apical stop to prevent the Gattaparcha from extrusion beyond the root canal is resistance form, and prevention of the Gattaparcha from being displaced from the root canal in coronal direction is known as endodontic retention form. How do we check the endodontic retention form? It can be clinically checked with a phenomena called tug back. When we insert the master cone to the working length, it should positively seat. Positively seat means there should be slight resistance in the apical one-third, so that when we try to pull the master cone above, there is subtle resistance that we feel, and that subtle resistance is called tug back. Okay. Now we'll talk about the techniques. Techniques for root canal preparation. So we have talked about the mechanical objectives and the endodontic retention and resistance forms. Now we'll talk about techniques for root canal preparation. One of the earliest technique given the year 1961 by Engel, one of the first techniques that was called standardized technique. Standardized technique. This standardized technique is simplest of the technique, and it is also sometimes called single working length technique. Why single working length technique? Because technically and philosophically, each and every instrument that would be inserted inside the root canal would be taken to the full working length. Neither short of working length nor more than working length. Definitely more than working length we do not use in any of the clinical techniques. Okay, so this is called standardized technique or single working length technique. What is happening? Just to illustrate you, suppose this is a root canal that we have to clean and shape with the standardized technique, and suppose the working length is 20 millimeters. It is just to give you an example of how this technique is used. Then we'll take the smallest file to bind at working length. We would start with the smallest file that binds at the working length. Suppose the smallest file is number 15K file that is inserted to the full working length, and we do cleaning and shaping of the root canals. Single working length technique. So we'll start with the smallest file, taking to the full working length, and then doing cleaning and shaping. And what is the method of cleaning and shaping we normally use? Suppose this is cross section of the root canal. We would place the file against the wall of the root canal circumferentially and do cleaning and shaping. Means this is the wall of the root canal. We would be doing circumferential shaping of the root canals all around the 360 degrees root canal is prepared. Okay. Then we would proceed to the next higher size. That instrument also would be taken to the full working length, and similarly we'll do the cleaning and shaping. Then we would progress to the next higher size, again insert it to the full working length, and then do cleaning and shaping. Like this we keep on doing till we achieve desired apical enlargement. How much would be the size of the prepared root canal is not fixed for any of the tooth. Okay, it depends upon what would be the method of obturation we would be using and what is the original dimension of the root canal. So please do not get confused. Whatever I am telling you, whatever figures I am giving you are just for the illustration of the technique. It is not necessary that the root canal preparation would always start from number 15 and terminate at number 25 or 30. Depending upon the original canal anatomy and dimensions of the root canal, we have to start. Maybe the 20 would be the first file, maybe 25 would be the first file to bind at the working length, or maybe number 10 would be the first file to bind at the working length. So it depends upon the canal anatomy. But we would always start with the smallest instrument that binds at the working length and then do circumferential cleaning and shaping. That means the canal would be enlarged 360 degrees all around the wall of the root canal. Okay, and the last file that we use is known as the master apical file. This is called as master apical file. The apical file means the largest file in any clinical technique that would be taken to the working length. Once we have achieved the desired, this technique is completed. So it is a very simple method of preparing the root canals by mechanical means. Each and every instrument, starting from the smallest to the largest desired instrument, is done and taken to the full working length. Two rotary instruments that work on this same principle of standardized technique are ProTaper and M2. These are two commercially available rotary nickel titanium instruments that work upon the principle of standardized root canal preparation. Means each and every file would be taken to the full working length. Just to give you an example. So we will talk about the advantage of such technique. The standardized technique is simple. There are no complex steps involved. Each and every instrument, starting from smallest to the largest, is taken to the full working length. Okay, and something that is simple is definitely rapid. It is time saving. Okay, we get a faster preparation of the root canals. If we talk about the disadvantage of this technique, it is related to obturation. How it is related to obturation? Because suppose number 25 is the master apical file that we have used for the final shaping of the root canal. Then correspondingly for obturation, we would be taking a number 25 Gattaparcha cone. Isn't it? We know that Gattaparcha cones are also ISO standardized and they are available in corresponding sizes as the files available. So if we talk about the above example, this was the file at which we terminated our preparation. Then to obturate such root canal, we would be using a number 25 Gattaparcha cone. And we would expect the Gattaparcha cone to go exactly to the working length, neither short nor long. But most of the time, this does not happen. Means your master apical file would be going easily to the working length, having a positive seat over there. But when you try to insert a corresponding size of Gattaparcha cone, it would, most of the times, would not go to the full working length. Why the Gattaparcha cone is not going to the full working length? Because of difference in manufacturing tolerance. Manufacturing tolerance. What is manufacturing tolerance? Means a number 25 file would be having an apical diameter of 0.25 millimeters. Similarly, a number 25 Gatta Parcha cone is expected to have an apical diameter of 0.25 millimeter, isn't it? So they should exactly conform, match with each other, and result in a good obturation. But there is a difference in manufacturing tolerance. Files are metallic materials, they can be manufactured with more precision. So ISO permits a manufacturing tolerance of plus minus 0.02 millimeter for files. Means each and every file from a manufacturer or different manufacturers. Okay, they can vary in dimensions from 0.02 millimeters, positive or negative. But on the other hand, the Gatta Parcha cones, they are plastic materials. They cannot be manufactured with that exact precision like files. So they have a broader acceptability of manufacturer tolerance. That is plus minus 0.05 plus minus 0.07 millimeter. Means a number 25 Gatta Parcha cone can vary in size from plus minus 0.05 millimeter to plus minus 0.07 millimeter. On the other hand, a number 25 or any other file can vary in size from plus minus 0.02 millimeter. So there is a discrepancy in the file size and the Gatta Parcha cone. And when your Gatta Parcha is not seating to the full working length, you'll have to make some unnecessary arbitrary arrangements because there is no exact method. You would be doing more filing so that the Gatta Parcha goes down. Then you would be again checking the fit of the Gatta Parcha cone. So it is a trial and error method, isn't it? So this difference in the manufacturing tolerance between the file and the Gatta Parcha cone is the potential and the principal disadvantage of using standardized technique of root canal preparation. The second technique that was given in the year 1969 by Clam and V. It is called step back preparation. Step back preparation. Initial name was step back preparation. This technique has been further modified, like Shielder gave it the name of serial preparation of the root canal. Serial preparation of the root canal. Other names are telescopic preparation. Telescopic preparation of the root canals. And the contemporary modification of the original technique is the Mulanese method. Mulanese, Mulanese method. Okay. What happens in this serial preparation or telescopic preparation? Suppose this is a root canal for which we have determined the working length, and again just assume that the working length is 20 millimeters. Then the phase 1 of root canal preparation, that is called apical preparation phase. This phase 1 is exactly the same as we have discussed above for standardized technique. Means we would start with the smallest file to bind at working length. Again, suppose that is number 15 file. We would take it to the full working length and then do again circumferential cleaning and shaping, just as we have discussed for the standardized technique. Then we would start with next higher size to the full working length and then do cleaning and shaping. Next higher size to full working length and then do cleaning and shaping. Suppose this is the desired apical preparation. This would be called master apical file, the largest file taken to the working length, isn't it? MAF stands for master apical file. Once we have reached the master apical file, the phase 1 is completed. This is the first phase of step back preparation of the root canal. Now we start with phase 2, that is called step back. We are stepping back from the working length. We are moving up from the working length. So we would take the next higher size. For our example, the next higher size would be number 35. It would be taken 1 millimeter short of working length. And then we do cleaning and shaping in the circumferential manner. Okay. This is called step back. We are moving up, moving back from the apical preparation. Next higher size, we would take further 1 millimeter short, or I would say 2 millimeter short from the working length, and then do cleaning and shaping. Like this, we keep on reducing the size of depth of preparation by 1 millimeter from the previous file. Okay, like this, we'll prepare up to the junction of middle and coronal 1/3. This is the principal step back method of preparation. Each subsequently larger size would be taken 1 millimeter short than the previous, and we keep on preparing the root canal. So when we are done with the phase 2 step back preparation, what would be the shape of the root canal that we get? This is the apical constriction. And then because of the step back, there are steps formed in the root canal. Isn't it? This is the phase 1 of the root canal, that is the apical preparation phase. And this is the phase 2 of the root canal, that is step back phase. And because we have been stepping back, there are formation of steps in the root canal. And you can see this internal shape of the root canal resembles a telescope. That's why it is called telescopic preparation. But what is the problem with this telescopic preparation? It violates the original mechanical objectives given by Shielder. Shielder says that whenever we prepare the root canal mechanically, it should be a continuously tapering funnel from the orifice to the apex. In this case, it is not happening. It is having steps in the root canal. So the next phase would be refining phase. We have to refine the preparation. This refining phase is divided into two, phase 2A and 2B. Okay, what is 2A? We would take a GG drill. Okay, when I talked about the instruments, we have seen what are GG drills. So this is a GG drill, and we do the coronal 1/3 flaring. Coronal 1/3 flaring. We have already prepared the apical 1/3 and the middle 1/3. Now we are doing a coronal 1/3 flaring. And after that, this is the phase 2A, and the final phase is 2B. That is, we take master apical file and then do cleaning and shaping. What is the master apical file? In the example that we have given, it is number 25 file, and as the name indicates, master apical file, it would be taken to the full working length. You would insert the master apical file to the working length and then do circumferential cleaning and shaping. All the steps that have formed in the wall of the root canal would be eliminated, and it becomes a continuously tapering funnel from the orifice to the apex. This is your step back preparation of the root canal. Divided into phases. Phase 1, apical preparation. Phase 2, step back. Phase 2A and 2B constitute the refining phases. It has advantages. The step back method of preparation is advantageous in cases of narrow and curved root canals. In the cases of narrow and curved root canals, as you can see, there are various phases: apical, middle, coronal. So it very well preserves the original anatomy of the root canal. It is a multi-planar preparation. So especially when the root canals are curved, this technique is very advisable. It is beneficial in that it preserves the original canal anatomy and procedural errors are reduced. If we talk about the disadvantage, what can be the principal disadvantage of this technique? It requires time consuming, it is technique sensitive, time consuming technique, isn't it? And there are chances of procedural errors. Why? Because there are numerous steps, meticulous method of preparation is there. So if we do not follow them properly, there are chances of procedural errors. But what you have to remember, it is specially suited for narrow and curved canals. Someone has asked me that is it used for C-shaped root canals? No, we do not normally use it for C-shaped root canals. Okay, C-shaped root canals are mostly prepared in a crown down method of preparation. Okay. The third technique is anti-curvature filing. Anti-curvature filing. It was given by Abu Ross. Anti-curvature filing. Basically speaking, it is the method of force application during filing. Just to illustrate what is meant by anti-curvature filing, suppose this is a mandibular molar that we are shaping with any technique of choice. We know that most of the instances the root canals are curved and not straight. This is the mesial side, this is the distal side, and this would be the root canal anatomy of this tooth. Okay. It is an anatomical phenomena that whenever there are curvatures in the root, the amount of dentine around the root canal in the inside of the curvature is less. The dentine around the wall of the root canal on inside of the curvature, not only for the mandibular molar but any tooth. Okay, mandibular molar I have drawn just to give you an example to illustrate it. So whenever there are curvatures in the root canal, inside of the curvature, the thickness of dentine around the root canal is less, and the thickness of dentine available on the outside is more. This is an anatomical phenomena, nothing to do with the clinician. So this outside of the curvature is called safety zone, and inside of the curvature is the danger zone. Okay. And suppose we are doing shaping of such root canal, a file is inserted inside the root canal. Okay, whether it is the standardized technique or the step back method of preparation, we have seen that the file is inserted to the root canal and we do circumferential cleaning and shaping, means equal amount of dentine is being removed from all the walls of the root canal. What is the danger of such thing? Whenever we are increasing the size of the file and doing circumferential filing, then the amount of dentine being removed would be equal from the safety zone and the danger zone. For the safety zone, it is okay. We can remove more dentine. But when we are removing equal amount of dentine from the danger zone, what would happen? The root canal would be enlarged and strip off its dentine support. So if this is the root canal, there would be a perforation in the wall of the root canal due to circumferential cleaning and shaping. Why? Because we are removing an equal amount of dentine, and as we progress to higher sizes of instruments, larger sizes of instruments, they would be more aggressively cutting the dentine outside of the curvature. More thickness of dentine is there. Inside of the curvature, less thickness of dentine is there. So with any of the technique for cleaning and shaping, whenever we are doing cleaning and shaping in a circumferential manner, there are danger of perforation in the wall of the root canal. Why? In the danger zone. This type of perforation that occurs in the wall of the root canal, this is called strip perforation. Perforation that occurs into the wall of the root canal. And clinically, how we know that we have started the cleaning and shaping? It's okay, the root canal has been cleaned. We are progressing to a higher size. Suppose we started with 15 size. When we reach the 30 size, suddenly we notice there is bleeding into the root canal. Although we are within the confines of the working length, there is sudden bleeding in the root canal which has been previously cleaned up to the smaller sizes. This sudden occurrence of fresh blood into the root canal that you are cleaning indicates an strip perforation. And why it happens? It happens due to equal removal of dentine from the outside and inside of the curvature. So we have to take into account the method of filing that is called anti-curvature filing. Whenever we are doing shaping of the curved root canals, we should apply pressure on the file against the curvature. Okay. More dentine is removed against the curvature as compared to inside the curvature, and it prevents strip perforation from occurring. So, strictest sense, anti-curvature filing is basically not a separate technique of cleaning and shaping. It is basically the method of force application, whether we are doing standardized preparation or step back preparation. Then another clinical technique is balanced force technique. Balanced force technique. This is a very unique technique. This is also important as far as your exams are concerned because a couple of times the questions have been asked related to this technique of cleaning and shaping. The balanced force technique was given by Rowan et al. Initially advocated by Rowan et al. The balanced force technique has certain important characteristics like only rotary motion is used. Normally, if you remember that what is the filing motion? The filing motion is a linear to and fro up and down motion. But in cases of balanced force technique, we use only the rotary motion. Second, there is apical pressure applied to the file. Apical pressure is applied and it is done with in a crown down approach. Crown down approach is followed. We do it in a crown down approach. If we remember the above two techniques that we have seen, that is the standardized and the step back technique, we have been preparing the apical 1/3, middle and the coronal 1/3. Okay. The crown down approach basically means can be represented as 1, 2, and 3, the sequence of preparation of the root canal. Firstly, we'll prepare the coronal 1/3, then the middle 1/3, and the apical 1/3. This is crown down approach. Okay. Step back approach. What is a step back approach? We have already seen we prepare the apical 1/3, the middle 1/3, and the coronal 1/3, the step back approach of preparation. So if this is the cross section of the root canal, okay. Whenever someone has asked me a question related to the anti-curvature filing, see, motion of use of filing, except for balanced force technique, would always be linear to push and pull motion. This is the root canal. We would be inserting it, applying pressure against the curvature, and then doing linear cleaning and shaping. We usually do not rotate the files inside the root canals. Okay. If at all some rotation is required, that would be 1/4 to 1/2 thumb. Okay. And this is the root canal that is we are preparing. We imaginarily divide the root canal cross section into four quadrants. Now, since we are working in a crown down approach, the coronal one third would be prepared first. So we will take the largest file that binds in the coronal one third. Definitely the coronal part of the root canal is wide, so we'll have to start with the largest file that binds in the coronal one third of the file. We insert it and give it a 90 degrees clockwise turn. Remember, we are using only rotary motion. We insert the file, it binds in the coronal one third. We give it a 90 degrees clockwise turn. The file has got flutes. It would engage the dentine of the root canal. It would become snug inside the coronal one third of the root canal. Now, what we will do? We will turn the file 270 degrees counterclockwise. CCW stands for counterclockwise. Now, imagine the file to be a screw. You're putting a screw inside the wall. When you turn it clockwise, it goes to go inside. When you turn it anti-clockwise, it tends to come out. Similar would be the tendency of the file. When you're rotating it counterclockwise, it would tend to come out of the root canal. You have to prevent it from coming out of the root canal. So you would apply an apical pressure on the root canal on the file while turning it counterclockwise. So you're maintaining apical pressure, turning it counterclockwise, it would machine the dentine, cut the dentine of the root canal. Okay. Then you would turn it 90 degrees again clockwise. What would happen? The file would insert deeper, isn't it? And then we turn it again 270 degrees counterclockwise, clockwise, counterclockwise, and whenever we are doing counterclockwise turn, there would be maintenance of apical pressure on the file. Clockwise, counterclockwise, clockwise, counterclockwise. We keep on doing this. Okay. We start from the coronal one third, then the middle one third, and then the apical one third. That's why it is called crown down approach. And once we have reached the working length with the file while turning it clockwise, counterclockwise, okay, we would remove the file from the root canal. The file would be pulled out of the root canal with a long clockwise turn. A long clockwise turn. We would keep on moving it clockwise and pull out. Remember, there would be no linear motion. So once we have reached depth of the root canal, we have to remove the file. It would not be pulled out like this. No linear motion. It would be pulled out by moving it, rotating it clockwise, and pulled out of the root canal. Why clockwise? Whatever debris has been there would be locked inside the flutes of the file and pulled out of the root canal. If we move it counterclockwise and remove from the root canal, the dentinal debris would be packed inside the root canal and obstruct the root canal. So this is what you have to remember, that 90 degree clockwise turn, 270 degree counterclockwise turn. We keep on preparing from the coronal middle to the apical one third. And once we have to remove the file from the root canal, it would be done with a long clockwise turn. These are the important aspects of your balanced force technique. Another method of preparation would be your double flare technique. Double flare technique that was given by Fava. Double flare technique is a hybrid technique. Hybrid method of step back and crown down preparations. If we divide the root canal into sections, okay, then we would be preparing the apical one third first, the coronal one third, and the middle one third in the last. This is hybrid. Okay, if we prepare it into this sequence, It would be what? Crown down. Okay. We prepare it in this sequence. First, second, and third. It would be step back. So these are the three different philosophies of preparing the apical, middle, and conal one third of the root canal. Double flare technique that was given by Fava is specially suited for narrow canals, just like your what? Your step back technique, narrow canals. So any of the method of filing can be used, either circumferential method of filing or the linear and rasping motion of the filing. But we'll prepare the apical one third followed by conal one third, and then the two portions of the preparation would merge together, and this is known as hybrid technique. So middle one third would be the last to prepare in the hybrid or the double flare technique. Apical one third would be the last to be prepared in the crown down technique, and coronal one third would be the last to be prepared in the step back method of preparation. Okay, crown down technique is basically the approach of preparing the coronal one third first, then the middle one third, apical one third. If we talk about the balanced force technique can be used with any canal configuration, but is mostly indicated for wide canals where rotary motion is more useful. Then another method is laser assisted preparation. Laser assisted preparation of the root canals. Okay, although this is not a very common technique, but there are certain laser tips that are called RC lays. RC lays. RC stands for root canal. Okay, RC lays. This is a laser tip that is applicable. What is the characteristic? It is a side firing laser tip. It is a side firing laser tip. Means it is a spiral shape of tip like this with a closed end which is placed inside the root canal. It would fire light from the vents present in the side of the tip. So instead of firing from the end, if we use the laser that is firing from the end of the tip, it would be of no use. It is placed inside the root canal. The laser energy would go in the apical one third and is causing damage to the apical one third area without doing any preparation of the root canal. So we use a side firing laser tip and we use a hard tissue laser. What is a hard tissue laser? Whose energy is absorbed by the hard tissues like dentine, enamel, cementum, etc. And hard tissue lasers are the principally erbium lasers and your excimer lasers. Hard tissue lasers. Erbium lasers, they are the most efficient for removing the dental hard tissues. And which erbium laser we use normally in the RC laser, erbium YAG laser is used. This is a wavelength of 2940 nanometer. RBM YAG laser tip is used. Okay. If we talk about the advantage, it is a rapid method of shaping and cleaning the root canals. The laser energy melts the hydroxyapatite, so simultaneously it seals the dentinal tubules also. Okay. If we talk about the disadvantage, it is got a learning curve. These lasers, they are technique sensitive, a learning curve is associated, and not a meticulous root canal preparation. The root canal preparation is uneven with the lasers. Okay, it is not well controlled. We never know how much of the laser energy would be absorbed circumferentially, and so it is basically an uneven preparation of the root canal. But what you have to remember, that a hard tissue laser is used, and most commonly we use erbium YAG laser. And what is the wavelength of that? 2940 nanometer. And what are the special characteristics of the laser tip? It is a side firing laser tip. Then we have non-instrumentation technique. Non-instrumentation technique. As the name indicates, non-instrumentation technique, basically it is generally the chemical debridement of the root canal without any mechanical instrumentation of the root canal. This technique was initially given by Lucy et al. And it basically uses a sodium hypochlorite pressure pump. So whenever the term non-instrumentation comes within the context of endodontic practice, non-instrumentation means we would not introduce any instrument below the root canal orifice. There would be definite pulp chamber access with the instruments. Cleaning of the pulp chamber would be there with the instruments, but we would not insert any mechanical instrument beyond below the root canal orifice. That is non-instrumentation approach. Okay. So what is done? Suppose this is a molar that we have to clean with the non-instrumentation technique. Definitely an excess cavity would be prepared and the pulp chamber would be cleaned. And after cleaning the pulp chamber, we would put a sodium hypochlorite pressure pump. This is a sodium hypochlorite pressure pump. It has got a large vent that introduces sodium hypochlorite under pressure into the pulp chamber. Sodium hypochlorite under pressure. And there is a small tube placed inside which suctions the fluid back outside. So there is a continuous flow of the sodium hypochlorite into the pulp chamber, away from it, and this is sealed onto the tooth with the help of a rubber cup, tightly sealing rubber cup. So it becomes a closed confine. After doing excess cavity preparation and cleaning the pulp chamber, we are sealing up sodium hypochlorite pressure pump onto the tooth pulp chamber and injecting sodium hypochlorite under pressure. Sodium hypochlorite is a very low surface tension liquid, and when it is injected into the pulp chamber with pressure or under pressure, it further travels down into the confines of the root canal. And we all know that sodium hypochlorite has a property of dissolving the organic tissue like pulp inside the root canal. So whatever organic tissue, debris, etc. present, they are flushed out by the copious irrigation of sodium hypochlorite under pressure. This is known as non-instrumentation technique, and it is basically chemical debridement and no shaping, mechanical shaping of the root canals is done. After doing such chemical debridement of the root canal, the pulp chamber is sealed with a suitable restorative material. So technically there would be no frank or formal obturation in such techniques because we have not shaped the root canal. So we would not be able to insert the regular obturating materials like gatta pacha inside the root canals. This is non-instrumentation approach of chemically debriding the root canals. So after the shaping aspect, if we talk about cleaning of root canals, they go hand in hand. The cleaning of root canals is mostly done with irrigants. There are anatomical irregularities like apical delta, apical ramifications, accessory canals that cannot be effectively instrumented with any of the available technique. To remove the pulpal remnants, necrotic tissue, disease causing organisms from such anatomical areas, we have to necessarily use irrigants along with the shaping of the root canal. That's why it is called cleaning and shaping. The commonly used irrigants. In today's session, I am not discussing in detail the irrigants. That would be a subject of some other topic, some other session. Just a brief, we'll talk about that. Most commonly, we use sodium hypochlorite. Other irrigants that we use are chlorhexidine, EDTA, antibiotic based irrigants, and we use certain combinations like Qmix, etc. Okay. The most common irrigant that is used is sodium hypochlorite. It has an exclusive property of organic tissue solvent. No other irrigant available till date has a property of dissolving the organic tissue, and that's why it is one of the most frequently used and popular irrigant. If we talk about the principal disadvantage of using sodium hypochlorite, then it does not remove the smear layer. We all know that whenever dental hard tissues are mechanically cut, enamel, dentine, cementum, there's generation of a microscopic smear layer. So if we are shaping the root canals with the help of mechanical instrument, the entire wall of the root canal would be covered with a smear layer. That smear layer would interfere with the addition of the obturating materials with the wall of the root canal. That has to be removed before obturation. So sodium hypochlorite alone cannot reduce or remove this smear layer. It is usually used in a concentration of 0.5 to 5.25% solution with an alkaline pH of 9 to 11. Okay. Other details we would discuss in some other session. Chlorhexidine is usually used as a 2% solution for endodontic irrigation. If you remember that chlorhexidine is also used as a mouthwash. In mouthwash, we use a lower concentration of 0.12 to 0.2%. For endodontic irrigation, we use 2% solution. Okay. This chlorhexidine has an important property of substantivity. Substantivity means it is capable of binding to the walls of the root canal and give an enhanced antibacterial action up to 12 weeks inside the root canal. Chlorhexidine. Okay. EDTA is usually used in 15 to 17% concentration. Okay. By itself, it is able to remove the smear layer. So there can be two set of questions for your examinations. One set of question is asking you how much time it requires for EDTA to remove the smear layer. Then the time required to remove the smear layer is usually 1 minute with 15 to 17% EDTA. That is a pH of 7.2 to 7.3. Okay, a straightforward question asking you how much is the time required for EDTA. Removal of smear layer with EDTA, 1 minute standard time. At times they ask you what is the exact protocol for removing the smear layer. We know that smear layer consists of organic and inorganic components. So there has to be a combination of two different irrigants. We do not mix them together, but we use them one by one. So smear layer removal protocols usually combines in the first step we use 5.25% sodium hypochlorite. It removes the organic portion of smear layer. Okay, in the second step we use 15% EDTA and it removes the inorganic portion of the smear layer. Okay, it removes the organic, sorry, removes the organic and removes the inorganic portion of the smear. A combination of sodium hypochlorite with EDTA, and the time that takes is 2 to 5 minutes in the combination of these two irrigants. Okay, another set of question. So please do not get confused. By itself, EDTA alone can be asked. It requires 1 minute for the removal of smear layer, and a standard protocol we have to combine sodium hypochlorite and EDTA, means we have to use two solutions. Coming over to the antibiotic based irrigants, they are basically MTAD or BioPure and TetraClean. Details we would discuss in some other session of these irrigants. They are also capable of removing the smear layer. By itself, they are able to remove the smear layer. And Qmix is a combination of PDT and triclosan. Qmix. Okay, triclosan is basically a chlorhexidine isomer. Triclosan. So these are the common chemicals and irrigants that we use. And the most important thing about irrigation of the root canal is the flushing action. No matter what irrigant, what concentration, what time we are using, flushing action is the most important aspect of your chemical debridement of the root canal. So volume of irrigant is the most important determinant in cleaning of the root canals. This is the cleaning techniques, the principles, the objectives, the retention resistant form, and a brief about the various irrigant solutions. These irrigant solutions we'll discuss in detail in some of the future sessions. Till then, happy reading. This is all from my side tonight. Thank you very much, everyone, for being connected with me. Happy reading. Take care. God bless you all. Thank you so much.